Thank you. So I want to talk today about trust, because I believe that at the heart of ensuring that everyone, including and especially those most vulnerable amongst us, receives the care, the support, and the services that they need to live their healthiest and best lives, is trust. Trust is visceral for so many of us. We feel it in our core. It underpins our most intimate relationships, our deepest and bitterest disappointments. It drives our behavior, our choices, our actions. And yet trust has for so long been conspicuously absent in how we design, deliver, measure, and innovate in healthcare. Instead, our systems are characterized by multitudes of insults, by small and large abrasions, by frustrations and failures that erode at the foundations required to develop trusted relationships for patients and communities. We fail to give people voice and agency in the decisions about their own care. And in failing to build trust, we failed to deliver care that is of value to those who need it. And I'm going to ask you for a minute to allow me to describe the experience of the healthcare system through the eyes of a patient whom I'll call Charlene. And I'm going to beg your indulgence a little further to allow me to tell this story in the first person. And as I talk, I want you to imagine that you're Charlene, or that I'm Charlene, because but for a couple of small details and a dose of luck, any one of us could be. So my name is Charlene. I'm 56, I just turned 56. I live in Boston. I'm a mom, I have 2 sons. My eldest recently got married, moved to Virginia. I'm so proud of him. My youngest is named Elijah. He's 13. He has autism, he has ADHD. He struggles to communicate and express himself. We live in kind of a rough neighborhood, and so I have to be extra vigilant for his well-being. But I'm grateful to have a roof over our heads. Most of the time, it's just us. Sometimes, if money's tight, I let my ex, Elijah's father, stay with us. I let him stay on the couch. He chips in for rent and bills. But I try not to too much, because when we were together, he used to get drunk and hit me. He says he's changed, but I'm not so sure. Between taking care of Elijah, protecting him, fighting with the school for every little thing, I don't have a lot of time for anything else. I'm on my way to the emergency room. The pain in my back is so bad, I don't know where to turn. I told my therapist about it again. She was worried too. She told me to call my PCP. But the earliest he can see me is 3 weeks from now. When I asked the woman on the phone if there was anything else she could do, she sounded irritated. I don't mean to be a bother, and I'm sure a lot of people complain, but I just know there's something wrong. I hear the doctor telling me that there's something in my spine, and it's spread all over my body, and it's probably cancer. I hear what she's saying, but I have to leave. There's no one to pick Elijah up from the school bus. I don't know how to explain it to these doctors and nurses. They seem so focused on asking me the same questions over and over again. What's my date of birth? How much do I weigh? When did I last see my psychiatrist? What meds am I taking? Am I really taking them? Am I hearing voices? Did I know my diabetes was out of control? For the 1000th time, do I want help quitting smoking? But they're not listening. And so I don't know how to explain to them that I can't stay, I'm just gonna go. Somehow I knew it was gonna end like this. No one in my family has lived much past their 60th birthday. I don't know why I thought it would be different. I didn't expect it to hurt so much, though, or to feel so alone. And I still know there's so many things I need to do to take care of my son, to make sure he's okay after I pass. Charlene died in the fall of 2012 of metastatic breast cancer. She was unique in that she was one of fewer than 35% of African Americans who received hospice service at the end of life. But despite the additional supports that program offered her, she was in severe pain, both physical and emotional. I was the doctor who met her on her first admission up from the emergency room. I was the doctor who received the handoff from the emergency department that described her in clinical terms as a 56-year-old African-American woman with hypertension, uncontrolled diabetes, bipolar disorder, obesity, medication noncompliance, as we tend to call our patients who don't do what we tell them to do, who'd showed up with back pain and tingling in her arms and legs. I saw in her chart that she'd had an abnormal mammogram about 1.5 years prior and that she'd been lost to follow-up, which means that she didn't respond to the phone calls and the certified letter that was sent to her home telling her to come back to the hospital. I reviewed her labs. I saw that her liver and kidney function was out of whack, but it was the CAT scan with masses in her spine, her liver, her lungs, that told the true story. I'll never forget breaking the news to Charlene. Her disheveled appearance, her confusion, what appeared to me to be confusion, and then my shock when she yanked the IV out of her arm, put her clothes back on, and left the hospital against medical advice. Charlene returned the following day. She walked back into the inpatient ward, right up to the nurse's station, unceremoniously said she's here, she's ready now to engage in whatever investigations and treatment we recommended. She came back on her own terms, having squared away what she needed to square away at home. But she gave me the gift of a second chance, because this time I could be present, to set aside the computer and listen. And I did. I learned about the primary care appointments that she'd missed because she didn't have childcare or transportation. I discovered that that mammogram follow-up was probably buried in the avalanche of things she was dealing with every single day to survive. I read about her visits to her therapist, complaining of this pain, that knowledge that something was not right. I had empathy for her primary care doctor, who was probably well-meaning, too busy seeing 20 or more patients a day to connect the dots scattered across her multiple electronic records, and to realize the catastrophe that was lurking within this patient's cry for help. And I observed the way her appearance, her way of speaking, her race, her education influenced others, including my own perceptions of her intellect and capability. And I felt her fear for her child, her son Elijah, knowing that this is a society in which Black boys like her son are considered and treated a threat to be attacked rather than a gift to be protected. And when Charlene died, something inside me broke a little bit too. Because at its core, Charlene's story is about trust. At its core, her experience is like that of so many others, most marginalized communities in our society, those individuals whose bodies bear the scars of trust broken again and again in their personal lives, in the fabric of our society that sees them as other and less than. And then, at their time of greatest need, from health systems that fail to listen to what actually matters to them, which do things to people and not in partnership with them, and whose very foundations are designed to achieve goals that are antithetical to building and sustaining trusted relationships. So let's unpack this a little bit. First, all of us here who are in any way involved in the healthcare system have to acknowledge that the values and legacies that underpin our system are steeped in a deep and shameful history of exacting violence on marginalized people, and that it continues today. There are so many examples. I will offer you two. In the 1930s to 1970s, the United States Public Health Service, in partnership with the Tuskegee Institute, conducted research on African American men without their consent, watched the progression of untreated syphilis, despite the fact that there was no treatment for that. In New York, on Staten Island, at the Willow Brick School for children with intellectual disabilities, most of whom had been abandoned there by their families and by the foster care system, researchers from New York University and Yale in the 1950s to 1970s knowingly fed children live hepatitis virus to observe them and to pit different treatments against them. They watched these children develop nausea, jaundice, liver failure. That's too far away. What about today? Today, where the cost of insulin in the United States has trebled in a decade. This is unique to any other developed country. This is a drug that was discovered and invented in the 1920s, whose patent was sold for $1. And yet for so many Americans living with diabetes, simply accessing a life-sustaining medication can put their entire life in financial jeopardy. And then we look around at the lists of top-ranked hospitals in the country, world-class institutions that are lauded for the research and medical care that they provide to those who can pay. So many of them abut low-income communities that they have very little regard for. They drive up property prices, they displace populations, all the while signaling explicitly and implicitly that the services they offer are not for the poor, the homeless, or the hungry. That too is a form of violence. This legacy continues, and our patients aren't blind to this. They know. They know this. Every single time a person who is poor, belongs to a racial or ethnic minority, is living with a disability, has a mental illness, identifies as LGBTQ, encounters the healthcare system, they know that they risk being subject to bias, to callousness, to disrespect, and sometimes even to overt violence. It's no surprise that public trust in the US medical profession has declined dramatically over the last half century. In a recent survey, a multi-country survey, low-income American families describe having significant mistrust of physicians and are less satisfied with their medical care than less low-income folks. Less than half of people surveyed in this study believe that physicians can be trusted. So let's acknowledge those foundations. Let's agitate and advocate for a better future. And let's ask ourselves, as we build and design interventions, can we earn back the trust of those whom we seek to serve? And that's the question that I and my colleagues asked when we set out to build our company, Cityblock Health. We asked, what would a trustworthy healthcare system look like? We started with the people. We hired and trained a new workforce of folks we call community health partners. These are individuals hired from the communities we seek to serve. We hire them for empathy, for listening skills, for tenacity, for trustworthiness. They are decidedly and deliberately not clinically licensed. We wanted people who lacked the baggage of the traditional healthcare system, who don't default readily to the lexicon of the patriarchy in healthcare. We surround these folks with a clinical workforce that's skilled, available 24/7, 365, doctors, primary care doctors, advanced practice clinicians, nurses, behavioral health specialists, psychiatrists. Each one has a role to play on the team, but none have primacy over the other. And that in itself is a radical act. We're divesting physicians in our model of power, and we're distributing it across the team, holding the entire care team with the power and the privilege of collectively owning that patient relationship. And then we thought about technology. And so much of what we see in digital technology today is trying to pit technology as a substitute for a trusted human relationship. We don't believe in that. We believe technology should be designed to augment and enable trust. And we built a platform that we call Commons that supports team-based workflows, task management, loop closure, decision support, that makes sure we keep our promises to the folks who we serve, that allows us to streamline referrals, to close the loop when we say we're going to do something, to have full transparency across the team, that we have a bedrock of common understanding so those important and critical details in a person's life don't get lost in the myriad of paperwork that folks have to manage with. And we designed our chart to be transparent and open to our members who we serve, so they can hold us accountable for fully and accurately reflecting their truth in our documentation. And finally, a deep commitment to value-based care. And we hear so much about that. It is so critical because unlike fee-for-service, where success is measured by the number of visits conducted, procedures performed, medications dispensed, for us, success is about long-term outcomes. It's about our members' health and their community's health, not just the units of healthcare that we deliver. And within this, trust is the most important currency. So we're here at NCQA, and so of course I have to talk about measurement, and I want to ask all of you and all of us, because we know that what we measure reflects what we value, and it drives what we do. So we're working to think about measurement that reflects the questions that matter to us. Do our members trust us? Will they keep coming back to us? Will they grant us the privilege of deeply and fully understanding what matters to them? Will they listen when we recommend, suggest, or nudge behavior change, treatments, interventions? Will they turn to us before going to the emergency room? Our success depends in a value-based world on our ability to earn and sustain trust. Therefore, we have to be able to measure it and drive towards it. And as always, I come back to Charlene in everything that I build and do. Would this system that I'm proposing have changed her experience if she had a person to turn to who was embedded within a system that she trusted, a system that understood what mattered to her, that cared about the questions that in between the words that were spoken, that knew and was prepared to deploy someone to knock on her door when she didn't follow up for her mammogram, who could sit in her living room and understand what it was like to live in her shoes, who would share her deep caring for her son and for the better future that we all want to see. And what would it mean to scale this approach across all of our communities, to build a healthcare system that is deserving of trust, to ensure that everyone, including and especially the most marginalized amongst us, receives healthcare delivered by individuals and systems that have earned and continue to earn their right to trust. Thank you.